populations because suicide is a culturally driven phenomenon. If we can agree that suicide is a behavior and behaviors are influenced by culture, then what suicide prevention looks like in one population may be different than what it looks like in another. For example, how we go about preventing suicide in the western states of the US, like Wyoming, Montana, even Alaska, Utah, Idaho, that's quite different than how we might prevent suicide in a place like Boston or Miami or Los Angeles. So for too long, we've done one size fits all suicide prevention in a way that does not speak specifically enough to a culture's values, their help-seeking habits, and frankly, the things that make them unique. Those are the really important and meaningful methods that we can reduce suicide within their population. And then, of course, it's driven by evidence-based research. On average, we know that there's a gap between research and practice. That is to say, it takes an average of about 17 years for research to get from the peer-reviewed journals to the front lines of our medical and mental health system where the clinicians can implement it. Now, when we think of suicidology research, it takes more like 30 years. So, what that means is the garden variety PCP or physician or nurse or mental health provider may be up to 30 years out of date with the most current research about how to best help someone with suicidal thoughts or feelings. And so that's the purpose of Prosper. It's to shorten that gap and make sure we are helping clinicians and others apply the latest and greatest information about suicide and suicide prevention. So let's move on here. Here are some select references that drive this content. Again, I will not read it to you. You've got this recorded. You can always look back. At a high level, suicide is not a mental health condition. It's a social issue. And I think we're accustomed to thinking of it as a mental health condition because it has often appeared in the context of depression or a borderline personality. It often is the responsibility of medical or mental health professionals. But what we're finding is that suicide is no different than homelessness, poverty, racism, bullying, or any other social issue, whether we're talking about intimate partner violence, substance misuse, a child not performing academically, or maybe the case of a divorce in a family. So these are all social issues that also have a nexus to mental health care and medical care. If we believe that the mental health and medical systems alone are going to solve this problem, we're kidding ourselves. Now, that's not because they're ineffective by any means. It's because the problem requires more solutions than simply medical and mental health ones. One review of suicide data across 37 states, looking at suicides from 2003 to 2017, found that 58% of those who had died by suicide had no mental health diagnosis. In a systematic review and meta-analysis of 20 research papers, it found that up to 21% of suicides can be averted if mental health conditions are prevented. So there's quite a bit of research looking at the contribution of mental illness and or mental health diagnoses to the problem of suicide, but also research looking at the fact that many suicides occur in the absence of a mental health diagnosis. In fact, we know that 12.3 million Americans think of suicide every year, yet about 48,000 kill themselves. That means 99%, over 99% of those who think of killing themselves will never do it. Now, we're not used to thinking of it as being so common or being a social issue because, frankly, we don't talk about it unless we're in the medical field. And even in the medical field, I don't think people hang out at cocktail parties talking shop about suicide. It's not necessarily an uplifting event or topic. It's not the kind of topic that people are comfortable engaging with. But what we know from the research is the more we talk about it, the easier it is for people to engage in it. And when I say engage in it, what I mean is to voice that they are struggling with suicidal symptoms or thoughts of ending their life. So even though it's a social issue, like other social issues, there's still a solution within the medical field. In a review of over 44 studies, 80% of those who died by suicide contacted a primary care provider within 12 months before they died. 31% contacted a mental health clinic. In a systematic review and meta-analysis of 24 longitudinal studies, now these were specifically on the younger population, what it found is that psychiatric disorders accounted for a significant amount of the risk related to suicide attempts. And this is specifically for ages 12 to 26. So let's be clear about this. While it is a social issue, that doesn't mean that medicine and mental health are out of the picture. We are so accustomed to focusing on medical and mental health solutions. But as we'll go over in the next few slides, there are many other things that we can be doing as a community, even as a medical field, to be helpful that is outside of what we do clinically in the room with a patient. So bad news up front, we've never seen a time in American history or any other country in the developed free world. I don't know what they do in non-developed countries or countries that do not freely share data, but we've never seen a time where we've reduced the suicide rates even by 20% and sustained that lower rate. We do see some good exemplars. The state of Colorado had some great success a few years ago with the Zero Suicides program. We do know that the VA currently is having some success over the last 3 years, decreasing their rates. But when we look at decades and beyond decades, we really don't see a substantial, sustained improvement. Even when we compare suicides to the top 10 causes of death, we're making some headway with those over numerous years, but not with suicide. When we look at the suicide rates scattered across the country, this is probably a 30-minute conversation in and of itself. So I'll try to be brief. You can see the darker the color, the higher the suicide rate per 100,000. And there are some commonalities between the states that have the lowest and highest. What I should say is among those who are in the top 10 for highest suicides, there are some similarities. So for one, population density is lower. So the more rural or frontier the state is, the higher the suicide rate. Now, some of that correlates to all of the social determinants of health, things like access to healthcare. But then there are some other factors associated with it, such as people's help-seeking behavior. And this is where we get into culture as well, is if someone in a rural environment doesn't have a doctor for 100 miles, they're going to wait till things are very bad before getting help for a physical condition. Note that there's also a culture of resilience. Some call it the cowboy culture. This resilience and perseverance. There's a value behind independence and self-reliance. So if they're not going to seek help for a physical problem, they're definitely not seeking help upstream for a mental health or an emotional problem. There's also the cultural value of not sticking your nose where it doesn't belong and for privacy. And so standard gatekeeper trainings may have limited success in some of these states, whereas in other states where the culture is different, they might be more viable. We also have the firearm issue, and I'm going to sort of pause on that. We'll cover that in a few minutes. In terms of means, 53% of suicides are with a firearm. It's by far the number one choice in America. That's not the case in comparable countries like Canada or the UK, England, Ireland, Wales. Suffocation, 27%. That includes things like inhaling carbon monoxide, hanging yourself, things like that, and other asphyxiation. So when we talk about populations, we have to acknowledge that there are some differences across populations. This could also be a full hour or 2 hour conversation. I'm going to hit the high notes here. The number one highest risk population are the Native Americans, and it's not surprising when you experience a near genocide that you might have intergenerational, multi-generational problems, to include substance use and suicide. And when we think of connectedness and affiliation and belongingness as a factor that reduces suicide risk, when your history and your culture has almost been eradicated, it's pretty hard to restore that sense of belongingness and that shared identity or collectivist identity that we know some cultures like the Native Americans embrace or embody. We also know that one of the highest risk and faster growing cohorts for suicidal individuals are African American females, ages 12 to 17. communities of color in general we are seeing a rise in suicides. Now, some of that is certainly due to social factors, things like racism, microaggression, macroaggression, you name it. But also, what we know is that we are increasingly doing medical and mental health research on communities of color, which is helpful because we're learning more. The sad part about it is obviously we're decades, maybe century behind where we should be. One thing I'd like to point out that's very interesting is when we look at Asian, Latinx, biracial persons, uh, and certainly Caucasians, we know that interpersonal factors are the most likely trigger or precipitating incident for suicide. Some estimates show that 40%, 42% of suicides are preceded by a relationship problem. But within the Black community, it's intrapersonal problems. And that's really unique because what it addresses or suggests the role of racism, the social context that might drive someone in the African American community to consider ending their life. So really helpful from more from a treatment perspective than an assessment one, but I just want to pause to double tap that. We also know that those who have autism spectrum disorder are at a 3.75-fold higher rate. They definitely have higher risk. Typically, it's among the higher functioning folks on the autism spectrum. When we think of intellectual disabilities, autism spectrum, we are at least a half century behind the curve with understanding suicide in these populations. We're currently engaged in a project with a group in London working with the autism spectrum community, making great strides with how we help them and also how we educate their parents, as well as some of their mental health and medical teams around suicide. But this is an area that unfortunately we need to do more on. We don't have any randomized control trials or other high quality studies looking at assessment strategies, treatment outcomes. Unfortunately, we only have observational research at this point. Okay, so shifting gears, we said a moment ago that gatekeeper programs may have some differential effectiveness in different communities, and without unmuting your mics and having a very high quality in interchange, suffice to say that if you see something, say something is a very important part of the solution, but it's just the beginning of the conversation. We know that gatekeeper programs may not solve 100% of the suicides. In fact, the research would show that it won't. There's some research that says it reduces risk in the population by about 30%. Um, as you look at these questions on the screen, you can see where different cultures and different values may align with gatekeeper programs and where certain cultures and values may not align with gatekeeper programs. When we do ask people post-mortem, we ask the lost survivors and those who knew the decedent, did anyone notice anything different about the individual? Many times people will say, yes, we noticed, but we just didn't think it was bad enough to ask the question. And that is so tragic that we notice the signs, but don't say anything. So there's something behavioral, there's something social, something probably cultural to this, to the limitations around gatekeeper programs. Oftentimes people know exactly what to say, they just don't know when and how to say it. So one of the things that we try to teach people as we reframe this problem is this is just like being a good person. Now, I know that sounds a little subjective, be a good person, but if you're walking down the street and walking on a sidewalk and there's someone laying face down in front of you, do you just step over them or do you stop and call 911 or tap them on the shoulder and say, hey, sir, ma'am, are you okay? I think most of us would do something, even if we step over them while calling 911. I think many of us would do something if we saw someone in crisis. But sadly, when people are struggling with suicidal symptoms, we don't see that as the same crisis as, let's say, a heart attack or someone who's unresponsive, or maybe we're in a restaurant and someone's choking and they don't need the Heimlich anymore. They need the back thrust. But still, technicalities aside, those are very obvious crises that many of us will jump to it to be part of the solution. But there's all this social stuff, all these biases that get in the way of us helping someone who's struggling with suicidal thoughts or suicidal feelings. We often ask people to raise their hand if they've asked the question outside of their professional role. But it's really no different when we think about being a good Samaritan, when we think about just trying to de-escalate a situation or resolve it. We've got to get people to understand that those who are struggling with suicidal symptoms absolutely want us to ask. In fact, when we talk to people who have survived their suicide attempt and we say, what was the last 2 weeks like before you killed yourself? Attempted to kill yourself. They'll say, I wasn't taking care of myself. I wasn't eating. I wasn't sleeping. I looked disheveled. My work performance was subpar. Everybody knew I was struggling, but not one person asked me if I was okay. And you know what that made me realize? I should kill myself. I am worthless. I don't mean anything to anyone. No one would care if I ended my life. That's really sad because those of us who witness someone in distress are not staying silent because we're trying to perpetuate the problem or validate the person's negative beliefs. It's just for some other reason. And so, what we have to understand as bystanders is we play a huge role in helping them, even outside of our role as doctor, nurse, or medical provider or clinician. We play an enormous role in being part of the solution outside of work. And we just talked about this. So we may make it worse by not asking. Now, I do want to be clear when someone chooses to end their life, that is their choice, that we cannot own others' behavior. We cannot blame ourselves for actions they've taken. They own those behaviors. And we own our behaviors. If we miss an opportunity to help, we must own that. So when we look at national suicide trends by age, this is sort of shifting gears for a bit to talk about the youth. We do know that we don't see any suicides typically under age 10, although between the ages of 10 and 15, we are seeing a rise. We are certainly seeing a rise in the 15 to 24 group. Just because we don't see suicides under age 10 doesn't mean there aren't suicide attempts or suicidal thoughts. And when we think about our youth, especially if we consider this a social problem, we have to think about what are other really difficult conversations. Suicide's a complex issue, it's a morbid issue, but are there other morbid, complex issues that we discuss with kids when they're toddlers or when they're in elementary school? Of course there are. One example is safe touches. No one sees or touches your privates except the doctor when one or both of your parents are present. Or how about stranger danger? Human trafficking is a big deal. That happens. So don't talk to strangers. If you ever get lost, find a mommy, right? That's what we tell the little guys. Also, how about fire safety? Stop, drop, and roll. When I was a child, the number of times stop, drop, and roll was hammered into my head. I definitely thought by the time I was 40, I would have caught on fire a dozen times. So catching on fire is very frightening for a child, right? Let alone being abducted or being touched inappropriately. So these are things that are safety issues, and suicide's no different. If if we don't see suicides before age 10, then in fourth grade, we should be talking to kids about it. And in fact, when they're in first grade, we should be having conversations that leverage their developmental capabilities. In first grade, they're very concrete, they're very black and white. They don't always follow rules. They're not angels. But for the big stuff, they follow rules. If you say, don't run into traffic, they get it. If you say, don't touch the hot stove, many of them get it. And so we can leverage that developmental stage where they do what we say. And it sounds like this. Hey, Johnny. Hey, Susie. If you ever have a friend and you hear them talking about wanting to die or wanting to kill themselves, come tell mommy or daddy, come tell us. You won't get in trouble. They won't get in trouble, but we want to make sure they're okay. And then when the child's older, like maybe fourth grade, we extend the conversation, expand it to say, hey, Johnny, Susie, if you ever have those thoughts, don't be ashamed. Don't be embarrassed. Come talk to us. We want to make sure that you're able to enjoy life and that you're not feeling that way about yourself. We also have to understand that children and adolescents, especially children, when they say they want to die or they want to kill themselves, that's really code word for I am completely overwhelmed and have no idea how to proceed with what's coming at me. They don't truly understand because of the lack of a frontal lobe. They don't truly understand what it means to completely end their life. They really don't understand the all of the secondary and tertiary order effects. So as adults, we have to consider when we hear kids say that, or adolescents, that's code word for I need help. I'm completely overwhelmed. We're going to move on from these slides. You can check them out on the recording. Um, the traditional methods we've used to assess risk involve sort of like a profiling strategy. And what we know when we look over the last 50 years of contemporary suicide research is we can't profile people. Yes, it's true that white men who own a firearm ages 46 to 68 kill themselves more than anyone else. We have 12.3 million people who think about it. And so we can't really profile. And in fact, we've been using these demographics to try to help us assess risk for a half century. How's it working for us? Are we reducing more suicides because we're using rubrics like this? Sadly, the answer is no. Here's one sample from the CDC showing the most common triggers. Now, let's be clear, there's no one trigger. Oftentimes, it's a combination of things. And we know that there's also this 80-20 breakdown. 80% of people who are thinking of killing themselves will show some signs or symptoms. The other 20% will not. So that 20% is comprised of two groups. The first group escalates so quickly that we don't have time to intervene. They're very impulsive about their decision to kill themselves. The other part of that 20% are so determined to die that they conceal all signs and symptoms. So when we think about these triggers, we're looking at the 80% here. And when we think about goals, about what kind of a reasonable short-term goal we can make in suicide rates, we should be looking at a potential to reduce by 80% until we've got tons of R&D money going to figuring out how to help that 20%. But suffice to say that these are the most common contributing factors. Similar to the last slide, we can't profile people. We can't look for everybody who's having a relationship problem and just give them a suicide screening like the Columbia Suicide Severity Rating Scale. It's an excellent instrument, but there are so many people with relationship problems who will never think about killing themselves. So unfortunately, we'll get a ton of true negatives that is just not time or energy or money efficient. We also know that we can't predict future suicides. This is a huge game changer. I'd like to pause for a moment, and anyone on this call who's a clinician, just reflect for a moment when you are with an individual who's struggling with suicidal symptoms. What is that nagging question in the back of your mind as you're going through the appropriate paperwork and the interview to understand their suicide risk? As you're doing a risk assessment, most of us have this question like, is he going to do it? Are they going to do it? Are they telling me everything? It's sort of this mindset that hopes to predict the future. And we've got two recent high quality studies showing that we cannot predict future suicides. So what that means is that sort of mindset of is this person going to do it, we've got to eradicate that. We've got to disabuse ourselves of any inkling that we're going to be able to predict it. Now, this should be a tension reducer for most. This should, pucker factor decrease. This should take a load off our shoulders, that our job is not to predict the future. So what is the purpose of risk assessment as we look at this shifting paradigm? Well, it's simple. It becomes a matching game. What are the specific needs of this individual, and what are the specific resources in this community that they need? Do they need 24/7 supervision, i.e., a psychiatric hospitalization? Do they need some sort of outpatient mental health care at a routine basis? So this is good news, honestly. It also means our documentation needs to shift, but we'll cover that at the very end. In the thousands of people we train every year, we see three main styles with how people operate and how clinicians operate. Although we've seen law enforcement and first responders operate this way, educators and those in the school system, most people take a better safe than sorry approach. We don't want to gamble with someone's life. However, let's take a look at that better safe than sorry approach. There's also the cavalier approach and the accurate approach, but let's start with better safe than sorry. Better safe than sorry approach says, I don't know if this person's going to kill themselves. Let's see if they'll take a safety plan and go to the hospital. The problem with that is the majority of people who experience psychiatric hospitalization do not have a positive experience. Now, I want to be clear. I am not kicking the psych hospitals in the shins. It is there to stabilize them. It is there to prevent them from killing themselves. And psychiatric hospitalization does that quite effectively. But what happens if you have a 16-hour wait in the emergency department before you get to the hospital? That's not fun. Again, not speaking pejoratively or derogatorily about the ED. That's their job too, is to triage. So it's our system that's part of the issue here. If we keep sending people in a better safe than sorry way through systems that are aversive and not pleasant, we should expect them to stop disclosing that they are struggling. So when we keep playing the short game with a better safe than sorry approach, what we're doing is unintentionally punishing help-seeking behavior. And so if you follow this red arrow, we're just maintaining suicide risk in our population for the long term. What we've got to start doing is playing the long game. The only time we play the short game, and that is that better safe than sorry, very hands-on approach, is when we walk in on someone ending their life. If we interrupt a suicide, that's a time to talk them out of it and to play the short game. All other times, which includes most brushes with the medical and mental health systems, we've got to play the long game. What the long game looks like is following the evidence-based research about what our role is. Our role is not to save their life. It's to follow what the standard of care and clinical research espouses, because that's what we have evidence for as giving them the best chances of living. And frankly, this is the bad news. They may still conceal information or withhold information from us. They may still kill themselves despite our best efforts. If our role and goal is to save them, we're going to be demoralized as clinicians. We're going to go home feeling bad. We're going to burn out. So we've got to shift our mindset about what our role is. Sadly, many of us are so focused on liability. And we're so worried about our license if we do the wrong thing. And that leads to all sorts of CYA behaviors and other better safe than sorry behaviors. But those aren't working. What works is what the research espouses. And we've got to reprogram ourselves that empowering the patient, developing mutual trust, so worrying less about your license and more about what the standard of care and clinical research says to do. If we do that, we are accounting for CYA. We are protecting ourselves with our license. And more importantly, we're empowering the person to help themselves. This leads to a positive experience, which in the long run will lead to future disclosure. Just a footnote here, the cavalier approach is common in many rural and frontier places, and it's sort of like, I'll pretend I'm a primary care provider. It's sort of like, I'm not asking every patient if I'm not screening for suicide universally. Number one, it doesn't work according to the research. Number two, if they say yes, I don't have a hospital or a behavioral health provider or a psychiatrist for 150 miles. I am not fishing for stuff that I cannot pull into my boat. And obviously, that's if we're not asking, we're not going to find out, because we know that individuals struggling with suicide do not easily disclose. So at the system level, when we have a ton of better safe than sorry behavior, it's sort of like build it and they will come. We just see increasing rates of psychiatric hospitalization for suicidal ideation and suicide attempts. Now, some of this increase in data also accounts for the recent trends we're seeing with pediatric or adolescent suicidal symptoms, like we looked at a few slides ago. So we have limitations in psychiatric hospitalization. At the end of the day, we've got to start leveraging outpatient medical community. That means our ER, our primary care, ED, primary care, yes, the mental health system, but we can't keep leaning on the mental health system for everything. And one reason why is because half of the mental health graduate programs in America do not formally train suicide risk management. Of those, slightly less than 50% that do offer that training, the average duration is less than 2 hours. Folks, this is grossly inadequate. The entire medical field relies on the mental health system with the confidence that they have adequate training, but sadly, they don't. I didn't get any training on suicidal symptoms or managing suicidal individuals until I was in my Air Force residency as a clinical psychologist. Yet I had 3 suicidal patients during my practica, so my pre-doctoral training. We also know when we talk to therapists who are licensed, Some of them avoid taking suicidal clients, and you all know this, you've seen this. And a third do not follow the evidence-based research. And when we ask them, why don't you follow it? They say, because I'm not comfortable, I'm not confident, I don't have the right skills or resources. Okay, we're going to go fast on this one, guys. We're cooking now. We've got about 25 minutes left. So, according to the Surgeon General, right? So this is HHS, this is SAMHSA, the Substance Abuse Mental Health Services Administration. These are the 9 comprehensive facets to a suicide prevention program. The ones circled in green, we do really well. And this is frankly the ones we've been doing for over a half century. It's your identify and refer, it's use 911, use 988. And that's wonderful that we're good at these, but frankly, we stink at the other 6. I'm going to start with increasing help-seeking behavior. This is culturally biased. In the West, in Wyoming, Montana, Alaska, they don't seek help, they self-help. So this cluster of programmatic facets should really be about bolstering independence, self-reliance, and self-help, or seeking help, right? So we've got to be more culturally coherent here. Postvention, we stink at postvention, and it's not that for lack of trying. We don't have any randomized control trials or high quality studies that tell us exactly how postvention works and the exact behaviors to do at a community level, at an employer level, at a school level, at a hospital level to help the community heal. We do know postvention is supposed to reduce contagion and reduce the likelihood of someone's loss being experienced as traumatic. But other than that, the research is not mature enough to be operational. Reducing access to lethal means. We hear so much in our popular culture about guns, and it's so extreme. It's like, get all the guns off the streets. Guns are killing our children. And then we hear guns don't kill people. People kill people. It's such a tired, extreme argument that is getting us nowhere, and it's certainly not addressing the real issue. The real issue is that you can love firearms and love suicide prevention. We are foolish if we believe that someone can't appreciate their Second Amendment right while also appreciating life, human life. We just have to find ways to have constructive conversations about firearm safety, increasing the security of the firearm during certain sensitive contexts. To be honest, most responsible firearm owners already increase the safety of their firearm when, let's say, they're having a party, when someone's going to be at their house who they don't know, when people are going to be drinking alcohol. So it's just another behavior in a cluster of other behaviors they already do. And if we message it that way, it hits home and they engage in safer behaviors, which reduces access to lethal means. So we've got to do a better job as a nation, as a state, whatever state you're in, messaging that. Effective care and treatment, there are some estimates, some samples that show, and this is related to the training data, the lack of training in mental health providers in graduate school. There's some data showing that 90% of mental health providers in America do not use evidence-based care. That's concerning. That means I have a 90% chance of getting someone who's not using the latest and greatest. Remember that in the field of suicidology, typically it takes about 30 years for that research to reach clinicians in the field. Life skills and resilience. Sadly, there's this tradition within the mental health field, and I know that I'm sort of pointing some fingers at the mental health field. I want to be clear. This is no one's fault. This is just what happens with inertia. In the mental health field, we want to convince people that it's okay to come in and to rely on us to help you. That help is available. It's okay to seek help. It's okay to not be okay. The unintended byproduct of that and all of the sort of trying to normalize mental health problems or emotional struggles, the byproduct is we foster a dependency between us as mental health providers and the patients. And it's such a pronounced phenomenon that sometimes we even have trouble discontinuing care. When we say, hey, Mrs. Jones, you've been seeing me for a year or two, your symptoms seem to be non-existent, you're functioning well. I don't think you need to come back anymore. And Mrs. Jones says, no, but I cherish this time. Can I please keep coming back? This is a common thing in the mental health community. And so we've got to figure out how to empower our patients better and how to help them fly much earlier in the relationship. Finally, we have connectedness. We're all connected with 5G. We've got the latest and greatest iPhone or cell phone or devices, right? But we're not really connected. So I would just ask you, I'm going to pretend like this is a room full of people. Raise your hand if you've multitasked at least once this week. Typically, when we do this, everybody's hand goes up. Okay. Now, raise your hand if at all this week you were typing on your phone while also talking to someone across the room or in another room. Typically, we get everybody raising their hand. That's not being connected. If we are so engulfed in multitasking and in our devices, we're not going to notice those subtle signs and symptoms of the people we work with, our family members, our friends. So even if we can take 15 minutes a day to just be present with the ones who are in our life, we're going to increase connectedness. And we know that increased connectedness reduces suicide risk. As we think about reducing suicide risk, not only in our jobs, but in our families, our friend circles, our communities, we can't convince ourselves that our job is to keep everyone alive, right? So in our professional hat, we follow the standard of care in the clinical research, right? And when we're working outside of our professional circles, our goal is just to reduce risk everywhere. That's the most viable goal that allows us to maintain our motivation despite losing patients to suicide or losing family members or friends. Is that if we put it on our backs, on our shoulders to reduce risk everywhere, that's achievable. To boost connectedness, that's achievable. But it's really hard to, frankly, we're putting too much on our plate or biting off more than we can chew to say we're going to save everybody. That's sadly, that's just not realistic. Even if we could, I would love that. So here are some things that pop culture says about suicide, and frankly, none of these things are entirely true. Uh, Sometimes it seems like they're true. Like for example, sometimes we think that suicidal individuals are just seeking attention, and while suicide is absolutely an escape-oriented contingency, the function, the purpose of a suicidal thought or action is to escape one's pain. Yes, over time, it may develop an attention contingency or component. That's not how it starts. And when we when we talk to people who have attempted suicide and lived, the majority will never attempt again. And when we ask them about it, they say, you know what? I didn't really want to die. I just wanted to be away from my problems. And that's something that we're not used to entirely understanding with such clarity. They don't really want to die. They just want to be away from their problems. It's related to another component, and that's ambivalence. So suicide is a state of ambivalence. When we ask patients or those struggling, most people, when they think about killing themselves, they don't really want to die. They just don't want to live with all their pain. Is that how you feel? A big light bulb goes on, and they say, "Yeah, that's exactly how I feel." And that's that feeling of being stuck, of being powerless, of needing to somehow act on it to get away from one's pain. And yet, what we also know, so the majority of people who attempt once and live will never attempt again. There's a smaller group that will wake up in the hospital or in their own house in maybe a pool of blood or urine or vomit, and they'll say, well, that didn't work. What now? And then there's a tiny group that will wake up and say, dang it, I'm so worthless. I couldn't even kill myself. Now I have to try harder. It's important to recognize those three groups because the majority of people who attempt once never will attempt again because they recognize it. Sadly, it took them getting close to dying to realize it, but I don't really want to die. I just want to be away from my pain. Okay, so as a part of this new model, we want to talk about the suicidal mode. We want to avoid using the words active suicidal ideation, passive suicidal ideation. These are words that are less contemporary and they're very hard to measure. I can't measure a thought, let alone a passive thought. It doesn't operationalize well. It doesn't lend itself to measurement very well. So for research purposes, even clinical practice purposes, but we can tell if someone's suicidal mode is on or off. When someone's suicidal mode is on, it means they're thinking of suicide. They're having those negative emotions, probably some racing thoughts. There are many behaviors and physiological events going on, like the fight or flight response is typically engaged. And it's that state where we'd say, you know what? This person's mental status might be compromised. They're not able to advocate for themselves or make good decisions. Then there are plenty of times where someone's suicidal mode goes on. Let's say I wake up at 7 a.m. in the morning, I say, I think today's the day I'm going to kill myself. But then as I'm getting in the shower and getting ready for work, because that's what suicidal people do, they're ambivalent. They're engaging in life-oriented behavior and thinking of killing themselves all at the same time. So I get in the shower, I'm getting dressed, say maybe today shouldn't be the day. Maybe I'll call my doc and see if they can see me as a walk-in. But when I get to the doctor's office and they say, "Oh, you're suicidal," we have to be clear. So are you thinking of suicide right now? No, I was thinking of suicide at 7 a.m., and that's when I called. I haven't thought about it since. So their suicidal mode is off, which means their mental status is typically intact. This is really important. Please rely less on active and passive SI and focus more on their state of mind. If I've made a phone call to seek help, that's evidence that I am rational and logical and making healthy choices. We've got to look to patients for some of the evidence behind where they are and what needs to happen next. And then we need to empower them accordingly. So I like to show this video. I'm going to stop share to maximize video. I like to show this video. It's Sinead O'Connor about 10 or 20 years ago when she was suicidal. She did attempt about 4 months after making this video, but just want to draw your attention to her thoughts, feelings, behaviors, and physiology. We'll only watch it for about 2 minutes, but please be aware that the volume is hard to hear, and she does swear a little bit, so forgive the crass language. But it's important when we're not in clinic to be able to observe what it looks like when someone's suicidal mode is on.
I hope that this video is somehow helpful. Not actually to me, but the fact I know that I'm only one of millions and millions and millions of people in the world that are just like me, actually. They don't have necessarily the resources that I have in my heart or my purse, for that matter. I was able to escape my country and escape stigma and escape all the things that meant it okay for everybody to use the fact that I suffer from 3 mental illnesses as something to beat me with rather than as something. I suffer from 3 mental illnesses as something to beat me with rather than as something with which they might, be compassionate. I'm now living in a Travelodge motel in the arse end of New Jersey. I've got a fucking kidney stone. I'm all by myself, and there's absolutely nobody in my life except my doctor, my psychiatrist, the sweetest man on earth who says I'm his hero. And that's about the only fucking thing keeping me alive at the moment. The fact that I'm his bloody hero. And that's kind of pathetic. And I gave so much love in my life. And I just can't understand how a person can be left so alone. And I want everyone to see what it's like. It's why I'm making this video. The mental illness, it's a bit like drugs. It doesn't give a shit who you are. And equally, what's worse? It's the stigma. It doesn't give a shit who you are. And suddenly, all the people who are supposed to be loving you and taking care of you are treating you like shit. And then when you're angry or you're hurt because they're doing it, it's like a witch hunt. They're pointing at you going, see, this is why we don't want to know. And it's like, oh, I'm fighting like all the millions and millions that I know I'm one of to stay alive every day. Which I'm doing because I love the people that are doing this to me. I'm not staying alive for me. For me, if it was me, I'd be gone straight away back to my mom. Because I've walked this earth alone for 2 years now as punishment for being mentally fucking ill and being angry that nobody would fucking take care of me. Specifically for being suicidal, actually, and for being angry. Everybody's so afraid of an angry woman, and what do? When I'm angry, I write angry emails. I don't stand screaming, shouting at people. I don't, So all these big hairy men that are supposed to be my family are so scared of the little woman who's sending them angry emails. They're like, that woman has been left. I've been wandering the globe for 2 fucking years. I'm a 5 foot fucking four little fucking woman wandering the world for 2 years by myself. Nobody in my fucking life, nobody except my business manager who can take any advantage he wanted. You know what I mean? And I'm all by my fucking self, and it's a crime.
So, pretty intense video, maybe hard for some to watch, but I think the important lessons here are to look at, frankly, what her
And it should.
thoughts, behaviors, and feelings were. And again, we can sort of uh, do a case formulation, case conceptualization. Just want to make sure we get this on the video so those who are watching in retrospect can take a moment and explore this. At the end of the day, if we can deactivate the suicidal mode, which we can do, research shows that we have the capability to do that, then great. We've just taken someone who doesn't have intact mental status, de-escalated them, and brought them to the outpatient world and empowered them, which is much more positive experience than a better safe than sorry, get them to the ER and get them to the hospital. Again, there are many times where psych hospitalization is very important in any situation where there's an altered mental status. But if we have the ability to restore that mental status, like someone sobering up from alcohol, of course we want to try to do that because it's more patient-centered, it's also more cost-effective. So as we take a collaborative approach, remember, Prosper is the integration of all the suicide literature that's effective. We have to consider the person as their expert of their own experience. We have to forge a collaborative relationship with them. We have to empower them to help themselves. So that includes teaching them about ambivalence. That includes helping them understand that they're feeling the way they're feeling because they've lost their self-identity or their meaning and purpose in life. We know if we use an effective crisis response plan, not only does that help deactivate the suicidal mode, but it reduces subsequent attempts by 76%. And a crisis response plan is not magic. It's some high quality coping skills, some of which we've known for decades from the dialectical behavior therapy literature. Um, but it's this style, it's how we work with people that also makes those self-management skills much more helpful. We already talked about playing the long game versus the short game. We've already talked about some sort of popular culture terminology that's not helpful. If you typically assess risk by going through these 3 steps alone, you are probably 30 years out of step with the research. We understand suicide at a more granular level now, so we have to differentiate between suicidal thoughts and non-lethal death ideation, also call it SI or DI. We have to look at prior attempts and behaviors. We have to assess the current episode, talk about reasons for living. It's talking about reasons for living that typically deactivates the suicidal mode. But the problem is we can't talk about that until we first talk about ambivalence. So if you've been trained in motivational interviewing, that is one of the most effective tools to talk with people about their suicidal thoughts. Finally, we do a crisis response plan and we do lethal means management. So some people use safety plans versus crisis response plans. A safety plan is in some cases it's semantics, in other cases it's literally used differently. It's where a safety plan might be used as almost an administrative tool, like, hey, patient, if you have those thoughts again, follow this guide. And that's not really an intervention. Whereas a crisis response plan, we're going to use it to help deactivate the suicidal mode, but over subsequent medical or mental health appointments, we're teaching the client or patient to use these coping skills earlier and earlier and earlier. We talked about this. Here's an example of a crisis response plan. When we talk about lethal means counseling, it's important to recognize that when we talk to firearm attempt survivors, people who've attempted suicide by firearm survived, we learned that 24% made the decision in 5 minutes and 70% made the decision in an hour. So back to the firearms discussion, we do not need to take people's firearms. We need to delay access by about an hour. In terms of documentation, this yellow statement with a line through it is how we used to document. Now we should be documenting more like what you see in red. And again, we don't want to over document. We just have to show that we're following the standard of care and the clinical research. Here's some resources for you. I want to save some time for questions. Here are some books we recommend. I don't get any kickbacks. There's no conflicts of interest here, but these are some excellent books for folks to pick up. The one on the left is for people in primary care. The one in the middle is typically for mental health providers. And then the one on the right is for any decision maker, a system thinker, someone who's responsible for programs, elected officials, other folks like that. Just a quick advertisement. We are doing a virtual version of this. This is a 16-hour program that today we've boiled into 55 minutes, but we typically do it in about 6 hours. The December iteration, it's 3 Tuesdays in a row from 2 to 4 Eastern time. We offer continuing education for a whole slew of professionals. If you use that QR code, that'll get you to the registration page. If you don't use QR codes or your phone's not working, just go to Eventbrite. And if you put in Prosper Webinar, you should come up with it. Join us on social media if you're interested. So whether it's X or LinkedIn or Facebook, we'd love to meet you. We'd love to connect with you. My email address is at the bottom right. Our website is at the bottom left. I'll take any questions you have, and I'm very grateful. Thank you, BestNotes, for having me today.
Thank you, Dr. Corso. Um, Everyone, if you could just put your questions in the Q&A portion, we'll try to get to as many as we can. Dr. Corso, just a quick question. I was surprised to see you didn't have anything on social media and the impact that it has on young adults. Do you have um, any comment on that?
Yes, the simple answer is it is a big part of the problem. Not only do we have some recent studies showing that it is increasing anxiety and depression among males and females, but it's definitely partly responsible for an increase in suicides among females, especially when it comes to things like self-image, body image. We know that two specific behaviors with social media are detrimental to females. One is the repeated consumption of images of others. It's developmentally appropriate to do peer referencing or social referencing where we compare ourselves to our peers. But when we're comparing ourselves to one picture they took when we've taken 500 selfies and not felt as good about ourselves as we feel about the picture we see of our friends, it can be damaging. And the second factor is following the lives of celebrities and believing that those extreme ideals are A, realistic, or B, maybe something even desirable. And so that all of that together is part of the problem. Good question.
We had a question here that said, can you talk about how to coach and guide parents who have child or minor who's experiencing suicide ideation?
Yeah, great question. Parents are typically petrified when they hear their kids utter death or suicide. The first thing is parents have to understand the difference between death ideation and suicidal ideation. Death ideation is quite common and lower risk. If you've been through graduate school, nursing school, medical school, basic military training, you've had death ideation. It basically means I'm completely overwhelmed and I wish I could escape all of this right now. Heck, if you've had a child during those first 24 hours when you don't know what to do and that baby's crying, you've probably had death ideation. It's a common human experience. And if parents can understand that, then they will be able to bring the appropriate level of urgency to their child's problem. So they have to know when it's suicide and when it's just, I'm completely overwhelmed and want to get away from it. The second piece is helping parents understand, and frankly, the community more broadly, that people don't usually kill themselves in front of others. So again, this is a social phenomenon more than it is a psychiatric one. People don't usually kill themselves in front of others, which means one of the most helpful solutions is to make sure the child or adolescent constantly is in the presence of others. Even if those others are peers, that still counts. There's something about people not doing it when there are witnesses. Now, the exception to that is people who weaponize suicide. That's a whole other discussion. In the context of a toxic relationship, in the context of a teen maybe telling the parent, well, I'll show you, when it's weaponized, but again, that's a very, very small percentage of suicides. So those are the two places that we try to start with parents.
Yeah, that's helpful. Dr. Corso, I wonder if you want to comment on this. One of our participants went back to when you said that about not wanting to die, and some of the patients that she's worked with, there was a main idea that I don't want to live, I don't want to exist, and I never want to wake up again.
Yeah. So I take a deep breath as I answer this one because it is a very tough one. Um, a very, if a patient is talking with you about their suicidal symptoms, by definition, they're ambivalent. People who are not ambivalent and suicidal are already dead. They don't come in for help, with one exception. And I do this because there's a tiny, tiny fraction of people who are determined to die, but they're not ready to do it yet. And so they'll come in and tell us, and maybe they have to wait for a child to graduate high school or wait for an elderly parent to pass before they feel comfortable leaving this earth, but they are truly resolved to end their life. A percentage of those are also what we would think of when we think of physician assisted suicide, or what in Canada they call MAID, MAID. And it's a program that, again, helps people who are terminally ill go with grace, so to speak. So it's a very complex part of the field where someone may have decided they're going to end their lives, but they're just not ready yet. In which case, our strategy is, well, look, I understand that you're determined to die, but while you're still alive, would you come in week after week and just consider talking about ways you can make every day tolerable? We'd be happy to help you improve your quality of life until that day. That's typically the best we can do with those folks. If we hospitalize them, they'll never come back. And then as far as physician assisted suicide, that's a whole other area of the literature that this isn't really addressing. None of these studies are really on that.
Well, you have been so generous with your time. Thank you so much, Dr. Corso. Just everyone else that's still on, I will send out a recording of this in the next few days. And we so appreciate you all joining us here. And we hope you have a wonderful rest of your day.
You're welcome. Thanks so much.
Thank you.